Okay, we'll go ahead and get started. Welcome everyone to our research event. We're excited to share what we learned about the economic impacts on women's access to reproductive health. This is an important and timely topic, and we will be sharing findings from our research where we partnered with researchers from University of Cincinnati. We'll also talk with an expert in the field of reproductive health from the Ohio Policy Evaluation Network, or OPEN. The Women's Fund works on systems level issues around women's economic self-sufficiency. We want to get to the root cause of systemic issues and change them there. Inequity is embedded in all of our systems, and we cannot fix these systems because they are working as they were designed. So we do the work of redesigning. Our vision is to design a community where all women can participate, prosper, and reach their full potential. We would like to thank our funders, Interact for Health, Stephen H. Wilder Foundation, and several generous donors, including Nancy Lane Gilman, Wishton Zraysat, and Patrick Points, and Carl Preisner and Aaron Heydrich. Our previous research has always been done with the aim of helping ensure women's economic self-sufficiency. It is the cornerstone of our mission. It's only when women can provide for the basic needs of themselves and their families that our community can thrive. We began pursuing this area of reproductive health as one of the many dimensions of self-sufficiency. We believe that women's economic mobility is a nonpartisan issue, and that when mobility is hindered by lack of access to healthcare, it simply must be addressed. We also carefully considered what our priorities are and how we can support other organizations who have already been leaders in this area. We don't want to reproduce the same work that has already been done, but we were absolutely certain that as the Women's Fund, we needed to do something about what we see as the most pressing issue facing women today. I'm going to turn it over to our Applied Research Director, Dr. Travis Spies, but I'll tell you a little bit about him first. Travis earned his PhD and master's degrees in sociology from the University of Cincinnati, where he focused much of his research on gender identities. He has presented research at local, regional, and national conferences and has work published in several academic journals. At the Women's Fund, Travis develops and manages our research agenda and our social enterprise initiative. Today, he will review the initial findings of our research on the economic impacts of restricted abortion access in Ohio, conducted in collaboration with other researchers at the University of Cincinnati. So Travis, I will go ahead and turn it over to you.
Thank you, Alicia. Our research utilizes several publicly available data sets to begin piecing together the economic consequences of restricting access to abortion care in Ohio. Previous research, like the Turnaway study conducted at the University of California, San Francisco, found that women who were denied abortion care and then gave birth experienced an increase in household poverty lasting at least 4 years relative to those receiving abortion care. Denying wanted abortions caused an increase in debt and a decrease in credit score. This study, which was the first of its kind, followed almost 1,000 women for 5 years from all parts of the country, ending in 2016. The legal landscape of accessing reproductive health care has changed significantly since 2016, which makes it even more important to understand the effects of new legislation for both individuals and state economies. The Kaiser Family Foundation reports that nationally, more than half of women who receive abortion care are in their 20s, and most are low income, earning less than 200% of the federal poverty level. The majority of individuals receiving abortion care are women of color, and 61% of women have at least one child already. Over 40% of women receiving abortion care have had some college education or completed an associate's degree. Our research is novel in that, to our knowledge, no one has analyzed the economic impacts of restricting abortion care in Ohio specifically. We estimate the additional costs of abortion restrictions that will be incurred by individuals, as well as the costs incurred by the public. These are the expenses distributed by the state from public assistance funds paid in part using taxpayer dollars. We've estimated these costs under 3 hypothetical situations that all assume abortion is not legal in Ohio. We find that regardless of situation, all women experience negative economic outcomes as a result of restrictions to abortion access. Last year, the US Supreme Court's decision in the Dobbs versus Jackson Women's Health Organization ruled the Constitution does not protect abortion rights and instead leaves that decision up to individual states. This decision overturned Roe v. Wade, which had previously upheld the constitutional right to abortion for 50 years. Immediately following this decision, Ohio's Senate Bill 23 went into effect. Commonly referred to as the Heartbeat Protection Act or the Heartbeat Bill, this law bans abortion after fetal cardiac activity is detected, which can be as early as 6 weeks into pregnancy. The law makes very few exceptions after 6 weeks. While the law is currently blocked by a preliminary injunction, there was about 3 months immediately following the Dobbs decision when an abortion was illegal. We use language from this bill to define how we count the number of abortions that might still take place in Ohio under this law and to measure the economic impact if this law goes into effect. Our aim is to determine the economic impact of restrictions to the reproductive health care, evaluating the consequences of legislation that has already been passed. And while our focus is on financial impacts, our analysis does not attempt to quantify the emotional and mental costs associated with abortion decision-making, which we recognize as an important component of women's lived experiences. We are not providing a rationalization for or against abortion itself, but we have taken into account many variables affecting economic costs for both individuals and the public, including earnings lost, transportation and childcare costs, maternity medical costs, and public assistance. And my last preface is to note that the economic impacts we evaluate in this analysis refer to the additional costs incurred by individuals seeking abortion care and the additional costs incurred by the public because of SB 23. We don't account for costs that are already incurred by individuals or the public in relation to the scenarios I'll describe. Before I dive into these 3 separate scenarios of our analysis, I want to share an account from a real person affected by this law. Researchers from the Ohio Policy Evaluation Network interviewed Martina about her experiences following the Dobbs decision while the 6-week abortion ban was being enforced. Martina is one of 40 Ohio women interviewed in this study. Martina is a Black woman in her 20s. She has 1 child and at the time of the interview was in school. Martina found out that she was pregnant at the end of May before the Dobbs decision. She wanted an abortion right away because she wouldn't be able to care for her child if she continued the pregnancy. However, she knew that she did not have the money for the consultation. By the time she saved up money for the consultation, it was the end of June after the Dobbs decision and when SB 23 was in effect. When she called 2 clinics in Ohio in late June, both told her that due to the new embryonic cardiac activity ban, she was too far along to be seen anywhere in the state. One clinic referred her to a clinic in Indiana and told her to schedule quickly because they were unsure how long abortion would remain legal there. She was able to get an appointment in Indiana in early July, but at the time, Indiana law required 2 in-person appointments. This meant that Martina had to travel to Indiana twice within a few days. As a result, she required additional family assistance with travel and childcare. Martina described feeling trapped and astonished that she could not get an abortion in Ohio, and she was frustrated that she had to travel to get care that she felt should have been accessible in her hometown. During her interview, Martina said that in the coming months, she wanted to focus on graduating from her school program. She even said that she likely never would have started that program if she hadn't been able to end the pregnancy. Martina's account highlights many of the concerns that women face when trying to make decisions about reproductive health. Decisions about family planning, education, and careers are balanced with concerns about paying for medical bills, transportation costs, and childcare. Our study utilizes data sets from state departments of health, the Ohio Department of Job and Family Services, the US Census Bureau's American Community Survey, and others to make predictions about individual and state costs. Three scenarios were developed to illustrate the potential range of economic impacts associated with restricted abortion access in Ohio for women seeking abortion care, as well as the economic impacts to the public. All three scenarios assume that Senate Bill 23 is in effect in Ohio. The three scenarios that I'll cover today include first, one where abortion care was accessed not in Ohio, but required to travel to another state. Second, a scenario where pregnancies in Ohio resulted in a birth. And third, a scenario where pregnancies resulted either in a birth or required travel to another state. In our first scenario, we imagine that SB 23 is in effect, banning abortions after fetal cardiac activity is detected, which can occur as early as 6 weeks gestation. All of the pregnancies that would have been terminated if SB 23 was not in effect require travel to another state to access abortion care. To complete the analysis for each scenario, we first needed to calculate the number of abortions that would still occur in Ohio under SB 23, and then determine how many of the pregnancies would require travel out of state to receive abortion care. According to the Ohio Department of Health in 2021, there was a total of 20,716 abortions completed in the state of Ohio. About 9,000 of those were to Black women, just over 8,000 to white women, and about 3,500 to women of other races. Given the exemptions under SB 23, we then determined the number of abortions that could legally occur in Ohio. These include pregnancies under 6 weeks gestation, those posing serious risk to the pregnant person, or other physical health concerns. This amounts to 6,266 abortions that would still be legal in Ohio under the 6-week abortion ban. We assume that these are distributed uniformly among racial categories. All other abortions completed, a total of 14,450, would require travel out of state to access abortion care in scenario 1. We assume that these are also distributed uniformly among racial categories. For each scenario, we wanted to anticipate as many of the costs as possible. In scenario 1, this meant that we considered the cost of transportation to travel out of state. This also included the cost of overnight stay in a hotel, parking or toll fees, and food purchased. We also anticipated that individuals traveling out of state would need to take time off of work and pay for childcare expenses if they were already parenting. The numbers that you see here in this chart represent the lowest estimate for this scenario where individuals are traveling out of state to access abortion care. We assume that abortion care remains available in Michigan and Pennsylvania, but is banned in Ohio and its other neighboring states, Indiana, Kentucky, and West Virginia. After considering all these variables, our lowest estimate amounts to a total increased cost to individuals of $2.6 million, or $184 per person on average. Now, this does not include the medical cost of an abortion, which varies on the type of procedure and how far into pregnancy a person is. And according to a 2022 study, this ranges between $550 and just over $5,000. Because these pregnancies result in an abortion, there is no additional cost to the public in this scenario. Now, in calculating the low estimate for scenario 1, we use the median increase in miles traveled to calculate transportation costs. To calculate the higher estimate of costs, we use the average increase in miles traveled instead of the median. The total increased out-of-pocket costs for individuals traveling out of state are about $3.2 million, or roughly $223 per person. And again, this does not include the medical costs of abortion care in this estimate. When we look at the breakdown of costs by race, we see that Black women in this scenario experience more of the total cost to individuals. This is because of the estimated pregnancies, more Black women are expected to travel out of state to receive abortion care, and all of the costs are experienced by individuals. While white women are estimated to pay between $1 and $1.2 million, Black women are estimated to pay between $1.2 and $1.4 million. Individually, all women pay the same amount on average, but as we'll see later, these costs may come at a greater burden for Black women due to income level. Let's move to the second scenario, where we'll still operate as though SB 23 is in effect and abortions are banned after cardiac activity is detected. Now, though, the pregnancies that would have been terminated if SB 23 was not in effect result in a birth. We begin with the same starting point, the 20,716 abortions reported by the Ohio Department of Health in 2021, distributed among 3 racial categories. In this scenario, the number of abortions that would still occur in Ohio under SB 23 remains unchanged. We assume, though, that all pregnancies that would have been terminated in Ohio during 2021 would result in a birth. We also take into account, though, that individuals who give birth do not necessarily choose to parent. A 2017 study finds that 91% of women who were denied an abortion who gave birth chose to parent rather than making an adoption plan. Within each racial group, we assume that 91% of births are parenting births, and the remaining 9% are adoption births. Our economic impact analysis focuses primarily on parenting births, although we know that there are individual and public costs associated with adoption births as well. To calculate the cost of pregnancy and who pays for it, we needed to consider the income level of the pregnant person. We know that from previous research that that the national rate of unintended pregnancy is higher for women with lower wages. We separate women into 3 groups: those with incomes less than 100% of the federal poverty level, those with income levels between 100 and 200% of the federal poverty level, and those with incomes 200% or more than the federal poverty level. But here's the thing. The Women's Fund's previous research shows that in order for a woman to have a self-sufficient wage, that is one that pays for a family's basic needs, a person really would need to be earning about 250% of the federal poverty level. So we're talking about incomes that don't really meet that threshold yet. Some of the reasons women with lower incomes are more likely to experience unintended pregnancies are because these women face more barriers to accessing healthcare services and face more challenges to pay for it. We applied national unintended pregnancy rates broken down by race to the respective racial categories of women in Ohio. What appears in this table is the distribution of unintended pregnancy by income level, by race, and applied to the estimated number of abortions that would have resulted in a parenting birth. Women of color have disproportionately high rates of unintended pregnancies at every income level, but the disparities are clearest at less than 100% of the poverty level. Roughly half of all unintended pregnancies among women of color are to those less than 100% of the poverty level. And here's what else we know. Over 70% of the abortions performed for Ohio residents during 2021, regardless of race, were for women with incomes less than 200% of the poverty level. So most of the women we're talking about are likely to be earning less than a self-sufficient wage to begin with. We consider this, though, to better anticipate the cost of SB 23 for both individuals and cost to the state of Ohio. I'll share the cost categories that we consider in our Scenario 2 analysis, but I'm not going to go into all of the details of the calculations today. We use data from the US Census Bureau's American Community Survey to calculate lifetime earnings by race and income level for women in Ohio between ages 18 and 30 years. Then we calculated what their earnings would be for the remaining years left in the workforce. Previous research shows that women often pause, delay, or abandon their educational and occupational goals as a result of pregnancy. And since education and occupation are directly related to income, we calculate the additional loss in lifetime earnings if SB 23 were in effect. This amounts to, on average, a loss of 3.3% in lifetime earnings lost by age 65. We also calculated the cost of early care and education up to age 5. Medicaid status of women was calculated and broken out by race and income level. We found that for women whose income was less than 100% of the federal poverty level, a vast majority of births were publicly funded. 87% of Black women and 79% of white women in this income category's births were publicly funded. Last, we considered what additional costs would be incurred by the state in terms of public assistance and SNAP benefits. We calculated utilization rates by race and income and applied the average cost of these programs to the number of parenting births. This table displays the lowest estimated cost to individuals and the public in Scenario 2, where all pregnancies not exempt by SB 23 result in a birth. We calculate individual lifetime earnings lost using women at the highest age ranges, since they would work fewer years and lose fewer lifetime earnings. Per parenting birth, the low cost estimate for individuals on average is almost $21,000. Now, a publicly funded birth includes prenatal care, labor and delivery, postpartum care, and the first year of infant medical care, as well as the next 4 years of medical care for the child. Here you also see public assistance and SNAP benefit costs to the public. Per parenting birth, the low cost estimate for the public is about $14,000 per person, or $186 million cumulatively. This table now considers the highest cost estimate in scenario 2. And the biggest change here that I want to point out is in terms of lifetime earnings lost. We calculate this number for women in the lowest age range because they have more years left to work and would lose more money in terms of lifetime earnings. In this scenario, individual costs for all races are, on average, almost $28,000 per person. The average public cost per parenting birth stays the same at just over $14,000. And you may be thinking to yourself right now, these costs only go up to age 5, right? Kids cost money after that, and this doesn't include the cost of feeding a child or providing a certain quality of life that isn't measured here. And you are right. There are a number of additional costs to individuals that we haven't yet considered in our analysis here. So these numbers are all really conservative for both individuals and for the public. We haven't considered yet the cost of publicly funded adoption births or childcare vouchers that are distributed from taxpayer funds. And these are all really important to consider in thinking about the economic impacts of SB 23. When we add all of these costs for both individuals and the public, we see the highest cost among our 3 scenarios. The total additional economic impact for all races is between $462 and $551 million. When we look at this broken down by race, we see that the cost of Black women's pregnancies in this scenario is more than other racial groups. This is due to a couple of reasons. First, Black women are estimated to have more parenting births in this scenario. Second, Black women disproportionately fall below 100% of the federal poverty level, making them eligible for and utilize more often public benefit assistance. Now, we know that it is unlikely that all pregnancies will result in a birth, just as it is unlikely that all individuals seeking abortion will travel out of state to receive care. In reality, it's more likely that it will be a combination of these 2 situations. So in our scenario 3 analysis, we consider what will happen if the pregnancies that would have been terminated if SB 23 were not in effect either result in a birth or require travel to another state to access abortion care. In scenario 3, some women will receive abortion care out of state, while some pregnancies will result in a birth. And we needed to estimate the number of pregnancies that would fall into these 2 categories. And so we relied on a 2021 study that showed how an increase in travel distance affected the overall birth rate. This study found that an increase in travel distance up to 100 miles to the nearest abortion provider is estimated to increase births by 2.4% overall, but varied slightly by race. We calculate the estimated increase in births if distance to the nearest abortion provider increased up to 100 miles. These are the numbers that we count as pregnancies resulting in a birth in scenario 3. And here's how we break down abortion outcomes for this scenario. Again, we start with the same number of total resident abortions in Ohio in 2021, 20,716. Of those, 6,266 abortions would still be legally provided under SB 23. The total births resulting from restricted abortion access that I explained on the previous slide are shown here. 91% of these are assumed to be parenting births, and 9% are assumed to be adoption births. Last, we assume that if a pregnancy did not result in a birth and abortion was not available in Ohio, it would require out-of-state travel to access abortion care. In this scenario, we focus primarily on the cost of the abortions requiring out-of-state travel and the parenting births. Results of the economic impacts of scenario 3 are summarized here, but we do have further breakdowns of these costs for individuals traveling out of state and pregnancies resulting in birth by race. All of the costs that we considered in scenarios 1 and 2 are also considered here. So things like transportation and travel costs, childcare costs, medical costs for parenting births, public assistance and SNAP utilization, as well as lost wages and lifetime earnings lost. The total costs in this scenario are between $98.7 and $118.3 million. These are both the individual and public costs combined. Broken down further, this amounts to between $22,000 and $29,000 on average per parenting birth to be paid for by individuals, and about $13,000 on average to be paid for by the state. The individual cost of traveling out of state to receive abortion care is still estimated to be between $184 and $223 on average, the same as scenario 1 estimates. And remember, this does not include the medical costs of care, which can be over $5,000. And here's what I think is the most important thing to remember here. Many of the women seeking abortions are not earning self-sufficient wages. They're struggling to manage the cost of daily living and take care of family members. The additional cost of traveling out of state to receive abortion care is often an overwhelming expense. And the additional cost of pregnancies resulting in a parenting birth are greater, even after factoring in more than $13,000 of public assistance benefits per individual. Let's again look a bit more closely at these figures broken down by race. The total additional cost for Black women in this scenario 3, including individual and public costs, is between $27 and $31 million. For white women, the additional cost is between $66 and $79 million. And for women of other races, this is between $6 and $8 million. Again, these are summative totals for women in a particular category. Because there are fewer women of other races reported in our data set, the total cost is lower. And considering this further, the differences between races also has to do with the number of abortions or parented births among individuals within each category. Based on our estimates, the number of parented births among white women is more than 2.5 times those of Black women, and the number of out-of-state abortions among Black women is about the same as white and other racial groups combined. If we consider how much individuals are paying, we still see some variation by race. The variation is due for a couple reasons as well. The first is related to whether pregnancies end in abortion or result in birth. The additional costs of pregnancies resulting in a birth are higher compared to the cost of pregnancies requiring out-of-state travel. Second, as we calculated lifetime earnings loss by income range, age category, and race, we found that white women as a whole are estimated to lose more earnings over their lifetime compared to other racial groups. And to be clear, the root of this observation is in racialized gender discrimination. Black women are paid less for the work that they do across job industries. So the wages lost over time is lower because they simply aren't earning as much to begin with. The cost of this scenario, both individually and for the public, depend not only on whether pregnancies end in abortion or result in a birth, but also on age, race, and income level. Let's take a step back now and consider the bigger picture here. We've created 3 scenarios looking at the costs associated with restrictions to abortion access under SB 23, a bill that has already been signed into law in the state of Ohio. The potential economic impacts of restricted abortion access in Ohio range from $2.7 million to $551.4 million based on abortions performed for Ohio residents during 2021. However, the potential additional economic impact of restricted abortion access in Ohio is more likely to be between about $99 million and $118 million. The additional costs incurred by women seeking abortion care range from $62.7 million to $82.3 million, whereas the additional costs incurred by the public are $36.1 million. Now, I'd like to bring this back again to the individuals whose lives are truly affected by SB 23. And I'd like to tell you Jade's story. She was another one of the interview participants in research conducted by Open. She describes her pregnancy, which she learned about after the Dobbs decision, before a preliminary injunction was set. So abortion was illegal in Ohio during the time that Jade is describing. Jade is a white woman in her 20s and a mother to 2 children. After experiencing pain and nausea, Jade went to the emergency department in late July, where she found out that she was pregnant. The doctor in the ED gave her the name of an OBGYN at the hospital, but Jade did not follow up with them because she felt that they would not be able to do anything for her. She knew that she wanted an abortion, so she scheduled a next day appointment at a clinic in West Virginia that told her that they would probably be closing in a few days due to anticipated changes in their state law. Jade had to drive alone so her partner could watch the children, and because she drove alone, she could not have sedation or pain medication. She would have preferred to have a medication abortion in the comfort of her home, but the clinic did not offer medication to those traveling from out of state. Jade received a doctor's note to give to work, but it was on clinic letterhead, and she did not want her employer to know that she had an abortion. She would not be paid for those missed days, and her partner had just maxed out their credit cards, paying for a hotel for her to stay in while her family had COVID. So the numbers that I shared with you today tell us just part of the whole story here. It's people like Jade and Martina who are left to navigate their lives differently when access to healthcare is restricted. They have to figure out where they can receive care that they are seeking, how to get there, how to take care of their families, and how to pay for it all. Their ability to be or become self-sufficient is jeopardized, as they must make choices related to their work, their schooling, and how to survive. So what have we learned here? This is a lot of information to take in, and we want to boil this down into some clear takeaways. In any situation, whether women seek abortion care out of state or if their pregnancy results in a birth, restricting access to reproductive health care comes at a significant cost for all women. Women will experience additional lost wages and lost lifetime earnings due to restrictions to abortion care. In fact, it is white women who are estimated to lose the most in lifetime earnings lost due to the existing racial wage gap. And remember, over 70% of the abortions performed for Ohio residents during 2021 were for women with incomes less than 200% of the federal poverty level. For a two-person household today, that would be an annual income of less than about $40,000. This is not a self-sufficient wage. Based on previous research that we've done, we know that the self-sufficiency isn't reached until individuals earn about 250% of the federal poverty level. So everything that we've talked about is perhaps most significant for low-income women who disproportionately seek abortion care. And when we apply a racial lens to these figures, we see that Black women are more likely to be starting off from a point of economic disadvantage. Black women's incomes disproportionately fall below 200% of the federal poverty level, and a greater number of Black women are estimated to travel out of state to receive abortion care as well, where they incur more of the individual costs of care. And we've really only just begun to truly consider the ripple effects of restricting access to reproductive health care. There are plenty of additional costs that we should still consider, including state costs of childcare reimbursements, or considering an even more comprehensive cost to individuals for raising children, or even how healthcare as a profession, as a job industry, is impacted and how that affects our state economy. But the bottom line is that for a majority of women, especially those who are low income, restrictions to healthcare access makes it even more difficult to achieve self-sufficiency. And with that, I will turn it over to our Director of Advocacy, Holly Hinkinson.
Thank you so much, Travis. Next, we're going to learn more about this important issue by hearing some of the stories behind these numbers. The Ohio Policy Evaluation Network, or OPEN, leads rigorous and innovative research on reproductive health care in Ohio and the region. This research collaborative launched in 2018 to study how policy affects reproductive health and equity at the state and regional levels. Hillary J. Gyrus is a senior research associate with OPEN at the University of Cincinnati. Her qualitative research explores the politicization of abortion care and seeks to center the voices of those impacted by abortion restrictions. Hillary earned her BA in Women and Gender Studies and Law and Social Thought from the University of Toledo and her MA in Women's Gender and Sexuality Studies from the University of Cincinnati. Previously, she worked for Planned Parenthood of Greater Ohio, where she developed and led a peer education program and provided comprehensive sexuality education in Northwest Ohio. Welcome, Hillary. We're excited to have you here. Thank you.
Thank you for inviting me. Happy to be here.
Could you start by telling us a little bit more about OPEN and the current projects that OPEN is working on?
Sure. So OPEN is a research collaborative. We have researchers based at University of Cincinnati, the Ohio State University, Case West, and several other sites in Ohio and also across the U.S. Our team is really interdisciplinary, but we work together to examine and understand reproductive health care in Ohio and the region. We have lots of different studies ongoing. For example, we have a study that surveys abortion patients in clinics. We have a collaborator who interviews Black women specifically about their reproductive health care experiences in Ohio. The team that I work most closely with, we conduct focus groups and interviews with OBGYNs, genetic counselors, clinic staff about how abortion laws impact their work every single day. Even, for example, OBGYNs who don't work in abortion clinics are still impacted by these laws. But today, the study that I'll reference the most involves interviewing people who saw abortion care after the Dobbs decision to understand their experiences accessing care. So I definitely encourage folks to check out our website. You can sign up for our newsletter or follow us on social media to keep up with our studies and our findings.
Great, thank you. So the research that the Women's Fund presented today relies on aggregate data from across the state. Open has produced a lot of research based on in-depth interview data that helps us to see how individuals are affected by changes to accessing reproductive health care. What are some of the most predominant findings that stand out to you?
Yeah, so since the Dobbs decision, I've interviewed 40 Ohioans about their experience accessing abortion care. And the findings from those interviews are so rich, but since today's topic is economics, I'm going to focus on that theme. Just a disclaimer, all participants gave consent to participate in the study and permission to share different aspects of their stories in settings like this. So just want to highlight that we do have consent and permission to share their experiences. As you know, after the Dobbs decision, Ohio banned abortions after the detection of embryonic cardiac activity on ultrasound, which generally occurs somewhere around 6 weeks. This forced many people to travel out of state for care and in many cases wait weeks in order to be seen in out-of-state clinics. This caused serious financial consequences and also mental and emotional distress for many people. And I can give you some concrete examples. So among our participants, several lost their jobs or were forced to work fewer hours due to the intensity of their pregnancy symptoms while they were waiting weeks for out-of-state care. So they're essentially too sick to work, and in many cases, actually, they were too sick to care for the children that they already had and had to rely on support from others in order to do so. For others, the unanticipated travel expenses really had a major financial impact on them. So some of them had to invest heavily in their vehicles in order to feel safe and comfortable driving them out of state. One participant told me she spent probably $1,100 repairing her car in order to take it out of state. Other people had to pay for things like gas, tolls, parking, hotels, bus tickets, and these expenses added up really quickly. So this meant people had to borrow money from their loved ones. One participant actually took out a payday loan, which, those have very high interest rates and could have a major financial impact for her down the road. Other people had to put off paying their electric bill, borrow money to pay rent, or put large expenses on their credit card. For example, we had one participant, Camille, which we gave all our participants pseudonyms, so I won't be referring to them by their real names today. But so Camille got a flat tire on her way back from Illinois and had to stop and put a $200 expense on her credit card to get a new tire in order to get home so she could pick up her children from soccer practice. And this meant when she got home, she also felt like she had to pick up additional hours at work in order to pay off that expense. We know that a majority of abortion seekers in the US are already parents, and that played out in our data as well. So a lot of them share that they felt they needed an abortion in order to adequately care for the children they already had. But in the meantime, they had to reallocate money that they would typically use for their children, such as, taking them on family outings or getting their hair done. They had to reallocate those funds in order to be able to travel for an abortion. But On a positive note, we did hear from folks that were able to work with patient navigators, that they were able to get both their travel and their abortion care often paid for. Patient navigators work with clinics or sometimes abortion funds, and they really work with people every step of the way to find an appointment out of state, figure out how to get there, and figure out how to pay for it. And so people really shared a sense of relief and comfort that they could get support from these folks. One participant shared that the patient navigator helped her to overcome the biggest, hardest hurdle of all, which was figuring out where to go. And she really didn't have any idea where to start looking for an appointment in another state. Just like Travis mentioned, though, our findings from the study demonstrate that these bans have an equitable impact on people who are already marginalized in our community. So people who are already experiencing racism, people who are living with low incomes, felt the greatest impact from the ban. And so our participants' stories highlight the economic precarity of everyday living. Many participants pointed out how expensive childcare, housing, food, and gas have become in the last couple of years. And so their stories really point to a need for not only changes in abortion law, so for example, removing the law that prohibits public insurance from covering abortion, but also the need for laws that more generally support parents and ensure affordable childcare, housing, and more general cost of living.
Thank you. Even in states where abortion is accessible, transportation is a barrier to accessing care. Our analysis takes into account round-trip travel distance, but I'm wondering what research Open has produced that can help us understand this a bit better. Are there any specific examples that stand out to you regarding the experiences of people seeking abortion?
Sure. So as Travis mentioned, people's economic situations and the complexity of their everyday lives really impacted their ability to travel and how much the cost of travel impacted them. And so I can give you a couple examples. The first example is Haley. Haley is a white woman from Southern Ohio. She started to feel ill shortly starting after a new job in mid-August of last year. She gets extremely ill when she's pregnant and was unable to work and was actually fired from her job because she called off too many days due to her illness. Eventually, she was able to get an appointment in Pennsylvania, but her vehicle was not safe to drive, so she had to rely on a family member to take her to her appointment. Now, she was able to get the cost of her abortion covered by an abortion fund. However, she had to pay for the travel out of her own pocket. She did find a new job, but she was really worried that her first paycheck would not be able to cover the cost of the travel, the cost of her rent, and then also utilities and groceries as well. Like many others, Haley experienced financial hardship after having to pay for travel, but for her, it meant housing and food insecurity. Other participants experienced other types of hardships beyond economics. And so one example of that is Mia. Mia is an undocumented Latina who's a student who also works to support her siblings and mother financially. She took Plan B in July of last year, but she discovered she was pregnant in mid-August. She knew that she couldn't continue the pregnancy while also working to support her family, and so she decided to seek an abortion. She was unable to be seen in Ohio, and so she traveled to Illinois for her appointment. And she had to take a bus because she's unable to drive. So the bus was quite expensive, and she also felt really unsafe during her trip. She left Ohio at like 3 or 4 in the morning, and she traveled alone. She's very young. This was her first bus trip by herself, and she was harassed by men several times during her trip. And she said that she felt really lonely and afraid during the whole trip. She also was unable to afford the good pads, is what she called them, in order to feel more comfortable during her abortion. So we see like these somewhat seemingly small expenses are then put out of reach for folks. So All that to say, Mia's experience took a toll on her financially, but also mentally and emotionally, and it put her in a situation where she felt unsafe. Several participants shared that they had a lot of anxiety about traveling. Many of them haven't traveled out of their home state before. They haven't traveled by bus before, and this is the first time they're traveling for an abortion. So they just have this heightened sense of fear and anxiety about that. But in general, folks expressed disgust, anger, frustration that they weren't able to get their abortions closer to home. And Mia and Haley's experiences are really just the tip of the iceberg. Folks they shared how they struggled to get time off of work, struggled to get childcare. People who couldn't afford hotel stays or didn't get funding for hotel stays were traveling, 5 hours to a clinic, having their appointment and traveling 5 hours home. So this need for travel, the cost of travel really impacted folks, not only financially, but mentally and emotionally as well.
Well, thank you. In our analysis, we looked at lifetime earnings lost due to having an unwanted pregnancy. This part of our analysis controlled for education, but what have you learned about women's educational attainment during an unwanted pregnancy?
So our study didn't look specifically at educational attainment. Several participants noted that they would not have gone back to school, they wouldn't have completed school programs that they were already in, or even made plans to go back to school if they had not been able to get the abortion that they wanted. A few noted that they probably still would have, it just would have taken them longer and cost them more and would have been harder to complete the programs. So while our study didn't look at long-term educational attainment or long-term economic well-being, we can look to a larger study for more understanding. So Travis shared earlier some data from the Turnaway study. That study was led by Dr. Diana Green Foster, who was also just named a MacArthur Fellow. So shout out to Dr. Foster. But this study interviewed people who were denied abortions periodically over the course of 5 years. And what they found, as you already heard, is that being denied an abortion is associated with increased debt, and people are less likely to accomplish their goals. Or I think we lost the slide there. Anyway, people are more likely to not be able to accomplish their goals, such as completing their education. And we also know from that study that people who are denied an abortion are more likely to experience bankruptcy, experience eviction, and have lower credit scores, which even beyond educational attainment has a major impact on families for a long time.
Thank you. So right now, in today's research, we're focusing on SB 23 and the effects of that particular law on the economic impacts to receiving reproductive health care. But there are other laws that impact how reproductive health care is accessed. Could you tell us a little bit more about these other laws and what effect they've had on healthcare accessibility?
Yeah, so if we're looking specifically at abortion laws in Ohio, we often refer to these as targeted regulations of abortion providers. These laws are written really to make abortion provision more difficult and to shutter clinics. They're often written under the guise of patient protection. They pretend to protect patients' health and well-being, but really they're unnecessary because abortion is actually very safe. It's actually safer than tonsillectomies, which are very, very common. Anyway, some examples of these laws. The laws sometimes mandate that physicians that work at abortion clinics have admitting privileges at local hospitals. They sometimes require that abortion clinics be regulated as ambulatory surgical facilities, which means they have to have really exact sizes and dimensions for their exam rooms and their hallways. And these criteria can be really expensive and burdensome to meet. And the law that probably has had the most impact in Ohio is the written transfer agreement law. So this law requires that abortion clinics have a written agreement with a hospital that's located within 30 miles of them that says the hospital will accept patients in case of emergency. This is not necessary because federal law prohibits hospitals from turning away patients in emergent situations, regardless of where they're coming from. And also, again, because abortion is extremely safe and complications are extremely rare. In Ohio, transfer agreements cannot be written with a public hospital, and oftentimes religiously affiliated hospitals decline to sign them. So in some areas of the state, they're really hard to actually get. For example, I am originally from Northwest Ohio, and Toledo used to have 2 abortion clinics. Today, there's only 1 left, and that clinic can only provide medication abortion. They cannot provide procedural abortions because it was just such a struggle to get a written transfer agreement in that part of the state. So basically, anybody in Northwest Ohio who wants or needs an abortion after about 10 weeks gestation has to travel to Columbus, Cleveland, Michigan, or farther in order to get an abortion. And so, again, the shortened version of this is these laws are not medically necessary. They don't do anything to protect patients, and they make it harder for clinics to stay open and operational, and this impacts access to abortion care.
Oh, thank you. Since we've been focused on the economic impacts of the law specifically for individuals in the state, we haven't yet considered what other kind of impacts that may have sort of a ripple effect from SB 23 or other laws related to reproductive health care. For example, one thing we haven't taken into account is how these laws might affect clinic locations more broadly. What can you tell us about clinic location closures or operations since SB 23 went into effect?
So we know that abortion laws before the Dobbs decision actually had a major impact on the number of abortion clinics in Ohio. We had 12 clinics close in Ohio since 2010. So clearly this is an issue that predates the Dobbs decision. We haven't had any permanent abortion clinic closures since Dobbs, but it gets a little complicated. So data from before the decision, data from the Ohio Department of Health from 2018 to 2021 shows an increase in the number of abortions in Ohio. This actually tracks with national data that shows an increase in the number of abortions in the United States more broadly. Data from the early months of 2022 showed that Ohio was again on track to see an increased number of abortions. However, there was a 50% loss in access during the period of time when the quote unquote 6-week ban, cardiac activity ban was in effect. So that's like late June of 22 to mid-September of 22. And after that ban was blocked by the courts, we never got back to the pre-Dobbs numbers. There's probably a number of reasons for this. It takes some clinics, a little bit of time to ramp up their services. Clinics were also seeing an influx of patients coming from other states at the same time that Ohioans were trying to get their appointments rescheduled so they could be seen in Ohio instead of traveling to another state for care. And then also maybe just general confusion. We do have research that shows that the more we talk about abortion bans in the news, the more people think that abortion is banned where they live. So there's probably lots of reasons for this, but all that to say, abortion laws that went into effect in Ohio over the course of the last 10 years or so, they kind of put us in a difficult position after the Dobbs decision. They contributed to the closure of clinics, and so now a large number of people from other states and Ohio are trying to get into a smaller number of locations. And again, this kind of put us in a tough spot after the Dobbs decision.
Yeah, absolutely. So we have all learned a lot today. What is the main thing you hope people will take away from our conversation?
Well, at the most basic level, I just want to remind folks that abortion is very common and extremely safe. It's a form of healthcare that people deserve access to regardless of the reason that they seek it. And in order for it to be accessible, it has to be affordable and it has to be available closer to home. And I think I'll just wrap by, again, thanking you all for inviting us to share some of OPEN's findings and to be able to share some of the experiences and the stories of folks who are behind the numbers that Travis shared with us.
Great, thank you. Hillary, it's been a pleasure speaking with you today. Thank you again for sharing your thoughts with us. And thanks for all you do to shine a light on this really important issue. With that, I'm going to turn it back over to our Executive Director, Alicia Miller.
Thank you, Holly, and thank you all for sharing the research and stories of real women facing barriers to economic self-sufficiency as a direct result of abortion restrictions. So, at the Women's Fund, our mission is to advance both gender and racial equity. We know that women make 82 cents for every dollar a man earns, and we also know that that wage gap widens when you disaggregate the data by race. Black women make 70 cents for every dollar that a white man earns. For that reason, prior Women's Fund research dug deeper into Black women's economic mobility and the wage gap here in Cincinnati. Some of the most concerning results: almost half of employed Black women in Cincinnati make $15 an hour compared to 27% of all women. And 32% of Black women in Cincinnati with a bachelor's degree are making less than $15 an hour. And that is nearly 3 times the rate of their peers. If you're interested in that research project, it is also on our website. You can see here. But I share all this to say all of our research is disaggregated by race to paint an accurate picture of how gendered racism perpetuates economic disparities. This is important to this particular project because the existing wage gap already puts Black women at a further disadvantage. Restricting access to health resources prevents them from having a fair chance at economic self-sufficiency. And while we were here today to talk about economic impacts, we do not forget that restricting reproductive freedom risks lives. We are adding a lens that reflects the Women's Fund's expertise, not to simplify the issue, but to amplify the importance. Thank you so much for joining our webinar to talk about our newest project. We hope that this information was helpful to you and that you'll be able to use it as a resource. And we're really excited about the next steps and what types of recommendations we can provide to the community to ignite change for women and their families. Thank you.